So we were in history taking, talking about the uh, vials of life. Make sure that if you receive the vials of life from the patient, that it gets put back in the little pill bottle and then put back into the refrigerator. When taking history from a responsive patient, when you're interviewing this patient, use a conversation type format, similar to a physician gathering information. Pretty sure we've all been to a doctor's office at one time or another, and the nurse will ask some questions and take some vital signs, and then the doctor comes in, and if he doesn't like something, he's going to ask for you to expand on it. He's trying to hear what you told the nurse. She's charted it. He's just double checking it. So this format of a conversation format reduces fear with your patient, promotes cooperation, and instills confidence in your skills and professionalism. Even if bystanders and family members greet you first, don't interview them before the patient unless the patient is unconscious or unable to communicate. And you're not going to be mean about it, but you want to make sure that you get the information from that conscious patient. Remember that the family members can be a valuable asset, but you may appear rude in the eyes of the patient if you're talking about them without talking to them first. So how do we gather this information? It's simple. Ask the patient, what seems to be bothering you today, Mr. Smith? Your goal is to determine what is bothering the patient the most. They may give you 3 different things. Well, which one, you're going to have to ask them, which one is the most important? What is bothering you the most? Find out if the patient's in pain, if they hurt, and where they hurt if they hurt. You need to try to use open-ended questions. Ask them, how would you describe your pain? Let them tell you how they describe it. And avoid yes and no type questions such as, does your chest hurt? Because there's a pretty good chance they're going to say yes. So medical patient assessment, we're going to assess the affected body systems or body part. Your responsive medical patient will have provided you most of your assessment information. You're going to gather more information from the S, from the sample history. Then you're going to focus on an area the patient complains about, whether it's cardiovascular, neurological, integumentary, reproductive, pulmonary, musculoskeletal soreness or injury, gastrointestinal, psychological or behavioral. And we're going to get more specific in the medical emergencies when we get to the individual medical emergencies. So we start our history taking by using a couple of mnemonics: sample, SAMPLE, and OPQRST. The S we can take from the sample history and add it in front of our OPQRST. So S stands for signs and symptoms. And we're going to use that to gather and incorporate in our patient interview with the OPQRST. With signs and symptoms, we need to know what other symptoms have they had. Have they had nausea with vomiting, or nausea without vomiting? O on the OPQRST stands for onset. What were you doing when the chest pain started? Onset. P, provocation, palliation. Does anything make the pain worse, or does anything make the pain better? And that can be simple as moving around makes it hurt more, or moving around makes it hurt more. Quality. Can you describe the pain? Is it sharp? Is it stabbing? Is it dull? Is it crushing? You can give them, a choice, but if you start asking, is the pain sharp and stabbing or dull and crushing, they might go yes, 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 yes. You need to break it down. Is it sharp and stabbing, or is it dull and crushing? Or does it feel like an elephant sitting on your chest? That type of thing. Radiation, region, R. Does the pain go anywhere? Point with one finger to where it hurts the most. With that said, there are certain, chest pain can radiate down the arm, up the neck, to the jaw. So that's what we're looking for, if it's radiating, and to where, the region. S, on a scale for severity, on a scale from 1 to 10, 10 being the worst, what would you rate this pain? Let them give you a number. Now, you're going to find out some patients have been through this before, and they're going to say, and you're not going to go, when you start taking a history, you're not going to go, okay, Mr. Smith, S, signs and symptoms. Please tell me your signs and symptoms. O stands for onset. When did this start? That's not how this works. The way it works is, this is a mnemonic to remind you at 3 o'clock in the morning to make sure that you ask these questions. Oh yeah, OPQRST, onset, provocation, palliation, quality, radiation, region, severity, and time. I got to make sure, and you can write that down in the margins on your report that you're writing to make sure that you find that out. It's just to refresh your memory. So on a scale of 1 to 10, some people, you'll start saying, on a scale of 1 to 10, 1 being the least, oh, it's 15. Well, that's not between 1 and 10, Mr. Smith. I'm sorry. Let's try this again. On a scale of 1 to 10, what is, with 1 being the least, 10 being the most, what would your pain scale be? Oh, it's a 3. Okay. So you kind of have to work with them. Sometimes they get a little anxious. And then time, when did the pain begin? They may say yesterday. They may say 2 hours ago, last week. Well, if the pain started last week, you can go back to the severity and go, well, if this pain started last week, what day of the week was it? It was Friday afternoon. What makes it so much painful at 3 a.m. Monday morning? What's the difference between Friday afternoon and Monday for you to call us at this hour? So A couple of them you can bounce back and forth when finding out when the pain did start. So that's the OPQRST, but we take the S out of the sample history to use, because we use the OPQRST more with the medical patient versus the trauma. Our sample history, we've already got the signs and symptoms if we used OPQRST. If not, stick the S back into the sample, and you start off with signs and symptoms. A stands for allergies. Are you allergic to any medications? Or think about, you can use sample also with the medical and trauma. What if you go to, I don't know, Joe's Crab Shack, and somebody says they're allergic to shellfish? Well, what did you have to eat, sir? Well, I had a cheeseburger. You can buy a cheeseburger at Joe's Crab Shack. Problem is, did they cross-contaminate it with a knife that had been used on shellfish? So you need to know if they're allergic to any medications, or are they allergic to food, depending on where they're at. M, medications. What medications are you taking? This can include recreational drugs or birth control pills, and obviously it's dependent on the situation. P, past medical history. In other words, what kind of medical problems do you have? Do you have a history of asthma or emphysema or high blood pressure or diabetes or heart problems or lung problems? Past medical history. Now, some people will have extensive past medical histories. Then you have to think of P as pertinent past medical history, meaning, are they calling you for everything in their past medical history, or is it one certain thing? Maybe they've had a history of blood clots and cardiac problems or respiratory, but what is it right now that you're dealing with? Are you complaining about leg pain, possible blood clots, or are you complaining about chest pain? So pertinent past medical history. L, last oral intake. When was the last time you had something to eat or fluids to drink? The reason for that is if you take the patient to the hospital and they need to have surgery, they cannot have anything in their abdominal or in their stomach because of the possibility of aspirating if they were to vomit. And this is especially true when you're dealing with the diabetics. When was the last time they had something to eat or drink? Because if their blood sugar is low, did they eat and not take their insulin, or take their insulin and not eat? You need to ask those questions. E, events leading to illness. Have you been ill recently? Your job is you're like a little investigator. And we'll talk a little bit about associated symptoms and pertinent negatives. Associated symptoms are symptoms that are associated with the condition that is causing the chief complaint. Associated symptom would be their chief complaint is chest pain. Well, usually they would have shortness of breath and pain that radiates to the jaw, and they're most of the time diaphoretic with a chief complaint of chest pain. Those are associated symptoms for chest pain. Shortness of breath, pain that radiates to the jaw, diaphoretic. Pertinent negatives are negative findings that would normally be associated with the chief complaint, but aren't in the patient that you're dealing with. The patient's complaining of chest pain, but has no dyspnea or pain that radiates to the jaw. That is pertinent negatives. Some special challenges in obtaining patient history, just I've changed the order based on most frequent to least, based on experience. Think about pediatric patients. Much, if not all, the history for a child and all of the information about an infant needs to be taken from the parents or guardians or caretakers, because that little pediatric patient probably can't tell you very much. Language barriers. Find an interpreter if possible. Best little interpreter you can find if you're in an apartment building is a kid that's about 8 or 9 years old. Usually they can speak the native language as well as English. The thing to remember if you're using a child to do some interpreting for you is don't use big medical terms with them. If you need to know if they're having pain in the abdomen area, be specific. Are they, is your grandma and grandpa or mom or dad having pain in their belly or around their belly? And then have them have the patient tell the little guy or girl to have mommy or daddy or grandma and grandpa point where the pain is. Keep questions straightforward, brief. Think about hand gestures. Think about some of the language diversity in the district that you'll be working. Confusing behavior or history of behavioral histories. There could be conditions such as hypoxia, stroke, diabetes, trauma, medications, and other drugs that could alter a patient's explanation. Geriatric patients could have dementia, delirium, or Alzheimer's disease, so they're not able to explain everything that's going on or understand what's going on. The patient that's anxious, anxiety. Expect anxious patients to show signs of psychological shock. They may be parlor meaning pale or abnormally white skin color. Diaphoresis, extremely sweaty. Shortness of breath. Numbness in the hand, feet. Hyperventilation syndrome. They're breathing so fast, they're breathing 40, 50, 60 times a minute that all of a sudden their hands and feet start cramping up. And this is known as carpal pedal spasms. Carpal pedal is spelled C-A-R-P-O-P-E-D-A-L. Carpal pedal spasms, meaning cramping, painful cramping of the hands and the fingers and the feet. They may have dizziness or lightheadedness, which could be an underlying medical condition. So sometimes you can't get good information from the patient, but we try to do the best we can. How about the intoxicated patient? Don't put the intoxicated patient, let me say something about intoxicated. You cannot call somebody drunk. It's illegal. It's against the law. You get in trouble for it. never ever on your patient care reports write that patient is drunk, because you are not qualified to determine that, because you have not been through the training to be able to recognize somebody that is possibly impaired. If you think it's a problem, then get a hold of the police. You have this intoxicated patient. Don't put them in a position where he or she feels threatened. There's a lot of potential for violence, and physical confrontations are high, because the alcohol dulls a patient's senses, makes a meek guy tough and a tough guy meek. Now, in your patient care report, when you do documentation, if the patient tells you they had 2 beers and holds up five, I had 2 beers and holds up 5 fingers, you can document that. Patient states that he or she had 2 beers while holding up 5 fingers, 4 fingers and a thumb, however you want to document that. You can write that, but you cannot say that they're drunk. The overly talkative patient, why may they be overly talkative? Excess caffeine consumption, Red Bulls, Monster drinks. They may just be outright nervous. They're scared. They don't know what's going on. Maybe ingestion of cocaine, crack, crank, or methamphetamines. And then sometimes they have multiple symptoms. They may give you the silent treatment. They may be depressed and crying. They may have hearing problems, may have visual impairments. If they're depressed, just be a good listener. Let them talk. You can talk to them. If they feel like talking to you, then be a good listener. Identify yourself verbally when you enter the scene, especially with the hard of hearing and visually impaired. You need to identify yourself when you enter. If you have to move any items, especially for the seeing impaired, make sure that you put those items back in the previous position so they can still get around their house. Explain to the patient what is happening in each step of the assessment and history taking process. So this is the end of part 3 of 5. I know there was a slight pause, so there actually might be a continuation of part 3.